GP in Coogee, and I've been a GP advisor to the Antenatal Shared Care program for about 3 or 4 years now. And this is May Tan, who's come on board last year as a GP advisor to the Shared Care program. Program's been running for a very long time and is a really valuable addition to the maternity services that are offered to patients in this area. So thanks for your interest and for coming on board to become part of the team. Initially, I would like to just do the acknowledgement of country. So the South East Sydney Local Health District acknowledges the Aboriginal and Torres Strait Islander peoples of Darwal, Gadigal, Wongal, Gwegal and Bidjigal peoples as the traditional custodians of the land we operate on. We pay our respects to ancestors and elders past and present. South East Sydney Local Health District is committed to honouring Aboriginal and Torres Strait Islander people's unique cultural and spiritual relationships to the land, the waters and the seas, and their rich contribution to society. So you're probably aware that the Royal has a very long history dating back to 1866, when the Benevolent Society established the first lying-in hospital in New South Wales. The hospital originally provided care to poor unmarried women during pregnancy, labour and after the birth of their babies. In 1905, Paddington Hospital opened, and in 1992, the obstetric services were transferred to this campus at Randwick. And that's a photo of the original Paddington. So it's been one of the longest operational obstetric services in the world. Just some housekeeping, guys. You'll notice that we have fire exits here and at the back, and there's toilets towards the back of the downstairs on this level. And I think there's toilets upstairs. Yes, and there's toilets upstairs as well. So if we could also just not necessarily have open drinks in here. Last year we had a little bit of an splash incident with a big Slurpee that was a bit unfortunate. So if we could just also, we'll try and give you lots of opportunities for questions. So feel free to interrupt and we will try and address things, but we'll try not to go down rabbit holes. From 11 o'clock, we'll have Louise Fay here, one of the antenatal shared care obstetricians. So we might save anything that's really specifically clinical until we have Louise here. So.
Hi, everyone. So I thought I would just point out that this is the key document. I'm sure that everyone is familiar with it or may have come across it, but in clinical care, I basically just have this beside me and refer to it for every consultation, no matter how many times you've done the first consult, etc. But so on here, so I'll just refer to it because I think it's really handy to actually have this because it sort of speaks to the slides as well. So the GP shared care maternity care contacts, these are the people involved, but you'll also notice on this that their phone numbers, like for example, the shared maternity care liaison midwives, Chantel and Huiling, who are down here today, they share the week. So Chantel's the first half and Huiling's the second half. So they're always here to be contacted if you have any clinical questions that come up that isn't covered on a clinical business rule or on this. The obstetricians that take the program are Siobhan Lee, Louise Fay and Stephen Coogan. Absolutely lovely. And the Danielle Snow's the midwifery unit manager who sort of coordinates the midwives who do take the clinics and do midwifery group care and MAPS. Maureen and I are here today. We're 2 of the 5 GP representatives or GP advisors on the Antenatal Shared Care Committee. And there's also 2 administration officers from the PHN, Ella Dullard and Lauren Thomas. So they're the people that you contact, that you would have contacted to become part of the program. And they also do CPD registration and things. So, yes. So, again, this document's key. I always have it sort of up and at the ready. So, it's good to have it laminated in your rooms. So, the different models of care. There's so many different options. Sometimes it can get a bit confusing. So, we're all here because of GP shared care. So, that's when the patient sees alternating visits between us and the hospital. It's only for low risk pregnancies. We'll have a slide further on, talking about which conditions are not suitable for this program. And they will have an opportunity to see a specialist if they need during the pregnancy, even if they're low risk. The second option is midwifery group practice. So that is when they have the one midwife that takes them through the whole pregnancy and hopefully will deliver their baby. So that's like having their own private midwife, and a lot of people like that option. Very, very oversubscribed. And so, you often have women at 6 weeks going, I really want this program. And I still haven't figured out, but even if you refer them at 6 weeks, it still isn't a guaranteed that they'll get the that option. And so that they've now set up this other option called maternity antenatal postnatal service, where they're basically getting the one midwife through their antenatal and postnatal care, but the delivery is done by a birth unit midwife. So it's not necessarily the same midwife, or won't be the same. So I should also mention that there's a Malabar midwifery group practice stream, just for First Nations people, and MFM midwifery group practice for women with complex needs.
Popularity of it. Women will often try and pressure you to do the referral for them very, very early.
Yes.
But in fact, e-referrals won't be processed until the results of the early dating scan and the blood tests are available. So there's no point until you've got that 7-week scan done.
It will slow it down.
It'll slow the process down. The patients will pressure you.
Yeah.
You just give a block answer that in fact you can't refer them until you have those documents.
In the past, they could self-refer online and then see a GP, but now that online system of self-referral is no longer available. So a lot of women are trying to come in to see us before they've had their early dating scan and things. So on that note, if you do send a referral and it's incomplete, you'll get a message back through HealthLink saying you need to attach X, Y, and Z, and to actually attach those documents, you can't unfortunately open the same referral you've given. You just have to generate a whole new referral. So you're kind of doing double the work if you don't wait until you have everything. Yeah, any woman who's discharged early from the hospital will be eligible to have that, but I don't think it's with the MGP midwife, is it? Oh, okay. So it's the same midwife. Yeah. Yeah, so I think that the way they've set up MAPS now, because in the past it used to be that women would get different midwives each visit, but now they're really trying to streamline it. So it's the same midwife that takes them through, even if they're not on the MGP program.
Yeah, because we've got a midwifery program for women who would be doing shared care, and that's separate again. So all women will get the opportunity to go home early, depending on, regardless of what model they're on.
Yeah. And then obviously the final model of care is a private obstetrician, which many women might take up in our area. So specialist pregnancy clinics available at the hospital. So there's obstetric medicine clinics. They're for women with obstetric and medical complications. That's taken by Sandra Lowe and Amanda Bartlett. High risk clinic, so diabetes in pregnancy, infectious diseases in pregnancy, preterm birth prevention clinic, hematological disorders and pregnancy clinic. There's also breech, anaesthetic clinic, twins clinic, perinatal mental health, and which includes a multidisciplinary team with psychiatrists, psychologists, and a perinatal midwife, mental health midwife. So preconception. So this is, ideally the first time we meet women on their pregnancy or conception journey. And a lot of you probably are familiar with this, but I'll go through it. So the ideal things to cover would be vitamins, so folic acid and iodine. If they are obese, it's important, you might want to consider increasing the folic acid dose. The carrier screening is another thing that's come on board in the last few years. That's now covered under Medicare for 3 conditions: cystic fibrosis, spinal muscular atrophy, and Fragile X. Thalassemia has always been under Medicare, and that's actually an important point to make, that any women at risk, and again, this will all be, there's page in here that covers it, which women should be treated, but which women should be tested for thalassemia. But I often just have it as a preset thing on your pathology request, just so then you don't miss it. But yeah, so about carrier screening, for those 3 conditions, it's covered under Medicare. And it takes about 3 to 6 weeks for the results to come back. If they are then positive for one of these conditions, of which like cystic fibrosis is almost 1 in 25 women are carriers, then in some racial groups, then their partner should then be tested. And if both partners are positive, then that's a discussion to be had with the genetic team, like a genetic counsellor. But but then the baby can also go down, like they can test that pregnancy to see if it's affected or not. So that's me going down a rabbit hole. The other thing to look out for is cervical screening, making sure the woman's up to date, making sure she's up to date with her vaccines, so specifically varicella and rubella. That's good to test. And then just talking about optimizing their lifestyle, I guess, in preparation for a pregnancy. So if they're a smoker, discussing that, encouraging them to quit, avoiding alcohol. It's now very much encouraged to avoid alcohol whilst they're trying to conceive. Exercise, maintaining exercise, but in moderation. There's also a Get Healthy in Pregnancy service that you can refer women to. There'll be more on that later this afternoon, where one of the people that runs the program will speak to us about it. Sometimes it's a good opportunity to go through tracking their cycles and the best time to, like, the most fertile period to target sex. And so I often talk women through apps like Flow or what's the other one? But yeah, Flow is the one I often use so that they can track, how regular their cycles are, and you can talk them through. The other thing is ovulation testing. So how to predict when they're about to ovulate, and then the day after is the ideal time to conceive. It's also important that, to let them know that it's not all on them. Like, the sperm has to be healthy too. So, 40% of subfertility are due to male factor issues. And so, I often say it's a good opportunity to get their partners in for a discussion. They need a little bit of encouragement and someone else to tell them that, not just their partners. So the other thing to mention is that is a complex medical conditions preconception clinic at the hospital. So if you've got women who've got 2 or more complex medical conditions, so like heart conditions or pre-existing diabetes, epilepsy, for example, you can refer them in, and they can get advice about medications and things like that if they're on a bunch of things. So early pregnancy appointments. So the first appointment to confirm the pregnancy is usually before 10 weeks. Women often book a 15-minute consult, but I think it's such a good opportunity and it should be prioritised. That's often why we run late in general practice as female GPs, I guess. So it's good, I guess, first of all, to explore their feelings around pregnancy. Not all women, 50% of pregnancies are not planned. And so, yeah, that's an opportunity for some non-directive counselling if it's a surprise pregnancy. But let's say they do want to continue, we can estimate their due date. Most of the time I just put it into the best practice and that comes out. But we do have a clinical business rule that can talk you through calculating that if need be. But yeah, so dating ultrasounds are very useful, especially if the women have irregular cycles. So it's best done between 8 to 10 weeks. A lot of women really want to know before that if everything's happening. But I often say that if you do it too early and they don't see a heartbeat, it can be quite an anxious wait for that 10 days or so to then see if there's progression in growth and to find a heartbeat. So I often say, I know it's really, really hard, but let's try and wait, unless, of course, there's early bleeding or something like that in their pregnancy. This is also a really good opportunity to flag that, from about 6 to 7 weeks, they may start to get some of the common symptoms of pregnancy. So tiredness is a big one. Nausea is a big one to discuss, and that's there's a lot more services around that now, but I often like to print out, there's a great Westmead fact sheet that sort of walks them through the different options there. So sort of talking about having, bits of, dried crackers and things like that. So they've got something in their stomach, and then stepping it up to like doxylamine, for example, and then going down the Maxilon on Danzatron routes. And I often say, just don't suffer through silence. Like, these are very safe medications. If you're worried, you can talk to the Mother Safe line for extra reassurance. But yeah, because a lot of women often try to avoid medications just because they're worried it might affect the baby, and then end up having really terrible dehydration and things like that. So it's good to flag that, there's treatments there. Breast soreness also is something to mention. And these all usually peak at around 9 weeks and will resolve by 13 weeks. But not always. Oh yeah, I think we've got a slide on that. Yeah, so if they are really dehydrated, there is a pregnancy day stay unit. They can come in and get IV rehydration, and that can really make a huge difference. It can really perk women up. Yeah, so you can call they call the GP shared care midwife or the pregnancy day stay. Yeah, I think we've got a slide on that. But
that's all clinical business rules. There's a protocol to follow for nausea in pregnancy and particularly hyperemesis gravidarum. There's very, very clear New South Wales Health guidelines on the steps to take and where the tipping points are based on a score.
I might just show, I'll show you the clinical business rules, because that's actually quite, oh, wait a minute. How do I get to this slide? We'll refer to the clinical business rules a fair bit. So I'll just quickly show you so this is on the website, so you can literally Google it and then go to health professionals, clinical business rules. So if there is anything that has come up and you're not sure, the other website I would love to plug is Health Pathways. That often covers a lot of these things in a very quick and easy, like sort of 2-minute page. But if you're wanting more detail and contact details that are always up to date, you can go on this. And I'm just trying to find the one on hyperemesis.
Antenatal pregnancy care.
Oh, okay.
Sometimes it's hard to find. There we go. There we go. Yeah.
There we go. So yeah, you do have to click into a few things to get there. And that is the business rule. So It's a lengthy document, but it does walk you through exactly what needs to be done, what investigations need to happen or should be considered, and then what treatments to implement there. Okay. Okay. All right. Okay, so routine investigations in early pregnancy. This is the one that's good to have as a pre-populated template in your medical software because it's quite lengthy. But basically, all women should have a full blood count, blood group and antibody screen, rubella and varicella testing. I should have added in there. Hepatitis B and C, syphilis screening, and HIV, so STI screening, and a midstream urine. That's one that's I often sort of try and talk around like how to collect a really good, clean midstream sample because often that might bounce back as like contaminated and they have to keep repeating it. So I always sort of make a point to say, please catch the midstream. So pee into the bowl for a few seconds and then catch the midstream. They do get another syphilis test again later in the pregnancy, 26 to 28 weeks. I actually often include these other tests that are listed. So iron studies, cervical screening we've already discussed, chlamydia if they are young or if it's indicated from their sexual history, thyroid function and thalassemia screening. As I said, I often just include this all in the one thing. And then we can discuss the dating scan with them then. So this is, so we've discussed some of the things to consider already. So cervical screening, carrier screening, lifestyle factors. I often bring up, there's a family planning fact sheet which sort of talks through a lot of these topics, and I often walk them through that. Food safety is a big one. So I use the Food Authority in pregnancy resource where they have got like the traffic light system of things to avoid, things to be careful of, and things that are safe. If they've got pet cats, that's important to discuss toxoplasmosis and CMV risk reduction measures. I think that's a big one that's come to the limelight recently. So I always make a big point of it, especially if it's a second-time mum with a young toddler, to avoid sharing any food with toddlers, avoid kissing on the lips, washing hands very thoroughly after nappy changes and things like that, because they're women that are probably at the highest risk. But I guess it's important for all pregnant women to know that, that they're immunocompromised from and susceptible to all infections, but in particular CMV because of that risk to the baby. And I think we'll be talking about more on that later today as well, which will be interesting. So COVID and influenza risk reduction. So just your respiratory, measures that we're all very familiar with after COVID. So first trimester, vaccination, things to discuss. So vaccinations, flu, there's 4 now that we recommend. So the flu shot, whooping cough between 20 to 32 weeks, COVID vaccination still recommended, and the RSV vaccination is now under Medicare and is recommended any time after 28 weeks. That will protect the baby for up to 6 months post-delivery, and rubella postpartum if they weren't immune on their initial bloods. The other thing to mention is low-dose aspirin. So before 16 weeks, if there is a risk, if she has risk factors for fetal growth restriction, GPs can now start, it's advised to start aspirin now. And so again, in your books, there is a flow chart on the fetal safety risk assessment. So if there's 2, it's a loose one. This is the This is the growth chart, but basically it actually might be a good deal of our women in the eastern suburbs. So if they're over 40 and they've had IVF, that is 2 risk factors, and we should be commencing low-dose aspirin before 16 weeks and continue that to 36 weeks. And that can significantly reduce their risk of fetal growth restriction. So that's a really good one to be familiar with. Yeah, totally. Yeah. And often I think with the IVF pregnancies, they have often been started by their fertility doctors. But if you pick up a woman and she hasn't started it, it's good to start. A lot of women will be like, oh, it says on the packet I can't take it during pregnancy, but you can assure them that they can, especially if they're at risk. Oh, yeah. Oh, okay, no worries. And the other thing that is good to mention, obviously, is the first trimester screening options. So there is the NIPT, which is the blood test that costs around $400 to $500, or they can go through the traditional sort of combined first trimester screening, which is the nuchal translucency scan and blood test results combined. But yeah, a lot of women do just choose to do the NIPT now. Plus, then if they do the blood test, it's important to do the early structural scan at around 13 weeks, because obviously the blood test doesn't pick up structural issues. Okay, so the second follow-up appointment is usually around 8 to 10 weeks. It's good to review all the results of investigations ordered, assess their symptoms of nausea, vomiting, that kind of thing, answer any questions they have. It's important to think about the early glucose tolerance test for women at risk. Again, there's another flow chart in the folder. And yeah, we've discussed the first trimester screening. So we've touched on this already, but all the referrals that come to the hospital should be done now through HealthLink, and that should be done once you've got all those results and with the all the blood results and the dating ultrasound. And usually it's ideal to get the women booked into the hospital by 14 weeks gestation. And then they'll subsequently be offered an appointment between 14 to 16 weeks with the midwife here. And you can always call the GP liaison midwife if you want to flag an urgent referral or a late booking, for example, if someone's moved into the area late. So you actually then have to open up a new referral. So you just do it again. So you have to open up a new referral through HealthLink. On this end, actually, I used to think, oh, are they getting like 3 or 4 referrals? But what happens on this end is the system combines matching things.
Yep.
Yeah, it'll come into their file here electronically. But that's what I was saying before. So if a woman's like pressuring you to do a referral before you have all the results, it actually won't be accepted, and it'll bounce, and you'll get a notification saying you have to attach X, Y, and Z results. And so then you have to then open up a whole new referral and do it again, if that makes sense. So it's often better just to wait until you've got everything together. Oh, morphology and things. So once they're linked in, they've had their booking visit, often I copy in the hospital, or do you also upload it?
No, I don't think that necessarily works.
Okay, that's good to know.
The best thing is patient has a copy of that result. And if there's anything, obviously, that specifically comes up on that, you'd be talking to liaison midwife anyway, probably to try and get them seen. If there's an abnormality or something, but if it's normal, then you're usually just noting it on their yellow card that it's been done, it's normal. And I usually say where it was done, and then if they need to chase the result, they can get it.
Yeah. Yeah, that's the other thing that's good. Now it's so easy for us to email patients results. I like to do that. And so then they've always got a copy when they're next coming to the hospital. It's always handy to do. Okay, so the booking and visit with midwives about 90 minutes, so very comprehensive, and they take a very thorough DV and psychosocial history. I was going to ask Chantel to talk to that, but yeah, so.
I've just gone to check because we've just querying on the slide it said aspirin from 16 weeks, but in fact it's 12 weeks. So
I think we need to commence it before 16 weeks. Yeah, yeah. Okay, so your antenatal visits. So at every appointment, it's important to do a blood pressure, weight, urinalysis if they've got any burning or stinging or urinary symptoms, fundal height, fetal heart rate with Doppler, and check for peripheral edema. Discuss how they're going, how if they're feeling movements. Often women start to feel movements around 16 to 17 weeks, and it takes a few weeks to get established, but we'll talk to that in the next slide. And then talk to them about where they can get help as well. On their antenatal card, there will be a few contact numbers. So across the top, there's often phone numbers that are really handy. If you flip to that, there's the Mother Safe phone number, which is really good if they're worried that they've taken a vitamin or taken a cream that's going to be harmful, that they can call Mother Safe. And yeah, the birth unit number is up there too if they've got any concerns after 20 weeks. And it's also good to talk about the sort of physiological changes that will start to happen through the pregnancy. So 20 weeks, good to have the protocol out. So that's often the first, after all the initial things. Oh, I think it's been taken. Anyhow, yeah, so things to go through is the full antenatal assessment, as we discussed in the last slide. Talk about fetal movements, give them their next pathology form for their glucose tolerance test, iron check, thyroid if they need that, and full blood count and blood group, and then discuss all the vaccinations. That's a good opportunity. And again, remind them, when they can call birth unit. So 28-week visit. Oh, I think I was good. Oh yeah, I'll finish and then I'll hand over to you. So 28-week visit. So this is kind of, they're getting a bit closer to birth planning now. So this is a good opportunity to start flagging birth planning and, how they hope to deliver and, what anesthetic and things like that they would like. They'll get a more in-depth discussion again at the hospital, but it's good to start having that discussion so they can start thinking about what they would like. Again, doing the usual routine antenatal assessment with the fetal Doppler, fundal height, blood pressure, and then going through any results. So this is, the visit to go through any GTT results or iron levels. Often around this time of the pregnancy, women, their iron requirements increase as their blood volume needs to expand. And so they might be low in iron and might want to consider supplementation. So again, there's a business rule. If they are positive on their glucose tolerance test, they should be referred to the diabetic educator as a first port of call, and then they'll be linked in with the diabetes clinic from there. It's good to discuss mood, go through the Edinburgh Depression Scale. Domestic violence screening is really important, drug and alcohol screening. There's an item number that can be claimed, the 16591. We were just discussing this. Often it's already been claimed by the hospital because they would have seen the women around 24 weeks. So you can check if it's been claimed already, but if it hasn't, then you can claim that. Again, check the vaccinations and if they need any, if they haven't had it, then that's a good opportunity. It's also important to note that from 28 weeks, women should sleep on their side to optimize blood flow to the baby. So it's good to flag that with women at this visit. And it's also the time that they can start booking in for antenatal classes and more education that will go through their birth planning sort of information in more detail. They're held, the antenatal classes are held at the here, and they're very, very low cost compared with the other sort of private birth planning classes, and they're very thorough, like going through what to expect early labour, ways to manage the pain, and it's good because they can come. I remember when I attended it with my partner, it was very much the first time you're like, oh, wow, this is really happening. This is actually going to happen in a few weeks. So, yeah, worthwhile to encourage women to book in because they get a lot more information, when they book in for those classes. And women going into delivery who've done the classes often a lot more empowered with information and feel a lot more calm and in control. And it's less daunting if they need something like an instrumental delivery because they know what that involves if they've been through it in depth in a class, whereas a midwife or a GP explaining those sorts of concepts in a half-hour appointment, it's just you're not ever going to cover it as thoroughly as in a class. So really encourage that. Now I will hand over to Maureen to take the rest of the talk.
So look, I should have pointed out at the beginning of this, the protocols are currently under review, and every time the last 2 or 3 meetings of intake we've had, we've promised that the next intake would be under the new protocol, but it keeps going backwards and forwards. So when the protocol changes, I promise you there will be a lot of publicity around it. So don't worry that you're likely to get left out of that loop. We're coming up to the 33 to 34 week visit, which will be about assessing the fetal wellbeing as well as the maternal wellbeing. So you're doing all your routine checks, your blood pressure, you're making sure if their blood pressure's up that you take it again, and we'll go through that a little bit later as well. If the patient's ferritin has been borderline, you might want to check that again. We don't really want people going into delivery behind the game already, and just also discussion about fetal movements and getting patients to be aware of what is normal, what is concerning, and also just reassuring patients that they can talk to you and come back if they're worried about anything, that they don't, if they feel like there's a change or if they're worried about something, that they can come talk to you outside of these routine visits, which really is what the beauty of GP shared care is, that we are their continuous provider of their healthcare, and so the first port of call for a lot of things. So the last visit that we'll have with our patients is at 38 weeks. So again, we're going to be assessing the fetal wellbeing and the presentation and position clinically. We're going to be reviewing all results and making sure that we've got our patients as prepared as possible to go forward. It's a good opportunity to talk to people about what their expectations are and particularly what their fears are. I mean, women, particularly for premips, the first delivery can be terrifying and they're not sure what they're going to experience and they're not sure whether they're going to be able to do it, and there's a lot of fears. So again, our ongoing relationship makes us the perfect person to open that question, and often then it makes it a much more accessible topic for them to bring to their next midwives appointment, if we've already sort of opened that door that it's okay to be frightened. Make sure that vaccinations are up to date. Maybe also have a discussion about what postnatal supports they've got, whether they've got extended family, whether they've got close friends, in this area. And particularly, a lot of my patients are from overseas and they have limited support. And sometimes just getting them to consider who their go-to people would be if they needed support postnatally is important. to get the patient to pre-book their 6-week consults if possible. Now, obviously, we don't know when the delivery is going to be, but just to remind them that once they have had the baby, to book in with us for their 6-week checks and an appointment for the baby as well. And again, another time to discuss fetal movements and getting patients ready to be ringing the birth unit when something happens. Now, I think that the beauty of the ease of communication that our system allows us is that patients can call for advice. And, you know, the birth unit is a busy place, but they will take calls and they will call people back and they will tell people, you know, answer their questions and guide them as to whether they need to come in or not. And so I think it's reiterating to patients that they don't need to hesitate if they're worried, that they can make that call. They don't need to hesitate if they think something might be happening. They can make that call. That's not something they need to be embarrassed or self-conscious for getting wrong. There's a reason why that's the port of call that the hospital opens after 20 weeks is because they are in the best position to advise people. So, yeah, we'd rather they call than either worry or miss an opportunity for an important intervention or that something goes wrong because they didn't call. So sometimes that's a really important thing for us to tell people, that it's okay. It's like when you've got patients with young kids, you know, I always often say to them, you know, if the time to go take the kid to casualty in the middle of the night is if you're worried, you know, if you're not comfortable. It's a bit the same, you know, if you don't know the answer, call birth unit. They'll talk you through it. Or if they're absolutely frantic, they'll take a quick kind of triage call and then call you back. So just that's probably a good opportunity for us to educate our patients about that being okay. So when to call the birth unit when you're worried or if you think something's happening. So our next encounter with the patient, after we've got the notification from the hospital that our patient's actually turned up at birth unit and had a baby, will be at the 6-week postpartum visit. So at this point, we may have seen the patient before this, but this is the next routine visit. So basically what we're looking to see now is that the patient has recovered from the experience of delivery. So we're looking to see that any perineal wounds have healed, that whether their lochia has ceased, whether their uterus has returned to its preconception size, and that there's no uterine tenderness. So we're going to also be asking about how the mum's going, how the bub's going. We're going to be trying to get a feel for whether this is going okay or not, so that we can help them cope better and make sure that everything's okay. And we can refer back up till 6 weeks. You can refer back to labour. There is a postpartum service that we can refer back to if there's problems. We're going to be looking at doing a Edinburgh mental health assessment, making sure that patients not suffering from any postnatal anxiety or depression. We're going to be looking at breast health. We're going to be looking at whether they're feeling okay with breastfeeding, and we're going to then, if there's any concerns, we're going to be advising them about lactation services, which are comprehensive at the hospital and really, really accessible and really good. So we might want to do look at whether there was delivery blood loss and whether or not patients need to have a full blood count ferritin rechecked. We might also look at whether we need to be doing a TSH if there's been thyroid issues in pregnancy. And we might think patients who've had gestational diabetes, talk to them about their postpartum glucose tolerance test that needs to be done. We're going to be looking at whether their pelvic floor has recovered or partially recovered from their delivery, and we're going to be giving them some advice on services available for that. Again, the hospital has a fantastic physiotherapy service. Patients may prefer private physiotherapists. We've got a lot of really expert advice around that. We might also want to just give patients a little bit of advice on returning to exercise. It's often patients are very keen to get back into doing their preconception exercise, but they may not yet be fully recovered in order to do that, and we don't want them injuring themselves. So, really emphasising to them that they need to exercise from the core up, and getting their pelvic floor back to being toned is probably their priority before they start thinking about their half marathon training again. Making sure that we mention to parents, which we probably have done before the birth, but again, you're thinking about the opportunity to update pertussis vaccination and flu vaccination for household contacts of the baby, and also then advising women about some information that might be helpful on the Raising Children Network. Again, a great resource where people can access very up-to-date, very helpful information from the comfort of their own home. We're also then going to be looking at that visit. There we go. At the baby. So at this stage, we still have the blue book, although I believe that's being looked at the moment, being updated to an app, which will be interesting. So a digital platform. So at the moment, everybody's still carrying their blue book around. And we're going to be making sure that the baby's gaining weight. We're going to be looking at its growth. We're going to be looking for anything that may have slipped by in its first examination in the hospital. So checking for heart, checking for hips, all those things that are part of that routine baby check, making sure that that there's nothing that's slipped through. We all know that you occasionally do find the murmur that was missed, or the facial features that have started to look a little bit less typical that you might need to refer on. Then obviously we're going to be giving the baby its first immunisation, so we're going to be talking to the patients about that and performing those immunisations. We're going to be kind of updating parents about if they're socially isolated, we're going to be trying to help them negotiate that, and hopefully they've been put into a parent group, but not everybody, it's not for everybody. So trying to help people navigate what other options they may have in terms of that. Infant feeding we've touched on, and talking to patients about SIDS and sleeping arrangements and safety about that. First babies have very comprehensively completed blue books. Second babies have bits and pieces. Subsequent babies possibly have their immunisations up to date in the blue book. But it is a great resource. But now that the immunisation register keeps the vaccinations up to date, I suppose it's not the Bible it once was. So going back now over some of the sort of stuff we've touched on up till now, patients are always very keen to talk about what foods they can and can't have. So there is some stuff on food safety that May spoke to. And so getting people into a kind of specifically designed website for that, rather than them going onto, influencer sites that have not necessarily accurate information. Basically looking at patients, whether they've got specific issues around their weight. So if they've come into the pregnancy underweight or overweight, if they need something specifically addressed there. And again, the Royal Hospital for Women has a dietitian service that we can utilise, and there's also the Get Healthy in Pregnancy program that'll be spoken to this afternoon. BMIs greater than 30 are really not suitable for shared care. So just, bringing that to the patient's awareness rather than them having to sort of expect that they're going to be in your care and then be handed over, just explaining to them that there are increased risks associated with a BMI greater than 30. They'll be referred straight into the hospital clinic. Yeah, so at booking. So it's just I suppose adjusting their expectation if they were hoping to do shared care at that point. That's fine, but it has to be hospital based. So so that comes to the next slide, which is what isn't suitable for shared care. So, we'd all love to be able to look after all of our patients through their pregnancies. Part of the beauty of general practice is that cradle to grave care of the patient. And but there are some things that are perhaps need a little bit more expertise than we can offer. And so we're looking at obviously BMI greater than 30, which I already mentioned, pre-existing diabetes. So they'll be seen in the diabetic clinic, multiple pregnancies for obvious reasons, complex psychosocial considerations. Now that's a difficult one because that who does that identify? I suppose there we're looking at people who are not perhaps functioning in the community. I think that's a bit of a broad exclusion, and I think that probably is on a case-by-case basis. If you have somebody who you're not sure of, it's probably best that you keep those options open and let that triage be done through the referral. Yeah, as much information that you can include in those HealthLink referrals, it really helps to triage. And if you're particularly concerned about somebody, you can always flag that referral. Any history of stillbirth, growth restriction in a previous baby or a preterm birth is not suitable for shared care. Rhesus isoimmunisation, and we'll come to something about that in a minute too. Complex infectious diseases. Suppose, that's a varied group of things, and patients with epilepsy, obviously they're going to have issues with, hopefully preconception, they've changed medications already to something safer if it wasn't, but obviously there's going to be changes required throughout and careful monitoring, and it's probably beyond our capability to be doing that in general practice. I think the biggest thing about this whole program is that in general practice, we're a little bit peripheral of everything. We sit in our own rooms, we're on our own, but we are part of a program that has a multidisciplinary umbrella, and we are not to be frightened to use that. That's what it's there for, that we are coming into a program that umbrellas us as part of it. We're not standalone. And so I think the biggest thing I can say to you today is, if in doubt, ask. If in doubt, refer back. Don't guess. If you're uncomfortable with something, ring the GP liaison midwife and talk over the problem. We are part of a system, and these protocols are designed to provide optimum care and safe care to our patients, and us engaging in them is part of that. So if in doubt, refer back to the Royal. So, don't be embarrassed. We can't remember everything. We're expected to remember guidelines on every disease known to man. You can't possibly, and you can't possibly know everything about everything. So my biggest take home today is, if in doubt, ask. You'll never be made to feel foolish, and there is so much help here. Obviously, if you have positive results that come back that change the patient's condition, you're going to be notifying. If you have identified growth restriction or growth retardation, you're going to be referring back. Anything that's abnormal on ultrasound, you're going to be referring back. The development of antibodies, malpresentations, psychosocial concerns, very important because there's a lot can be done to build some structures around patients if they know. So if the Royal knows that there are problems evolving, there are a lot of things that can be done for the patient to cushion them through. But obviously knowledge is power. Nobody can help if they don't know there's a problem, that we often know there's a problem. And generalised pruritus is another reason that you would refer back. So looking at what happens at hospital. So there's under 20 weeks, patients are going to come either through EPAS or emergency department outside of hours. And over 20 weeks, it's to the birth unit. So as I said, patients on the yellow cards have all those phone numbers for the birth unit. They also may touch base with pregnancy day stay if we feel like they need to be monitored for hypertension, or if they've got hyperemesis and need rehydration, but the GP makes that referral. And obviously after hours, some patients will end up in emergency, and they can then liaise with the obstetric services from there. And obviously not everything that happens to somebody in the 40 weeks of their pregnancy is related to their pregnancy, but it may impact their pregnancy. And so obviously we're going to be sending some patients to emergency with other things because other things happen. Bleeding in pregnancy. It's always a cause for great anxiety in patients. And, you know, sometimes it's not clear what the problems are. So we're going to be under 13 weeks, we're going to be doing a quantitative beta HCG, looking for that result to double every 2 days. And we're going to be doing an ultrasound to make sure that we have an intrauterine pregnancy and to get some idea of whether that pregnancy has ongoing viability. And we're very blessed around our area with great obstetric ultrasound services. Probably a good pointer to make sure that you're using obstetric ultrasound services, not a general radiology service. Very important that we can rely on these reports. Unfortunately, you know, it does happen where important things are missed, but just because the service was not expert enough to find the problem. So if obviously if there's concerns, we'll be referring through EPAS. Yep. Really for routine stuff, no. A lot of the obstetric services will provide packages where they will give discounts for patients to have all their obstetric sonography undertaken in that service. So it's worth looking at your relationship with some of those practices and seeing what they're offering. Also, patients sometimes will ring around different services and do a bit of bargaining. But around here, a lot of the services do package up quite well, and it is still expensive, but perhaps not prohibitively so. That then leaves the hospital services for the real problem pregnancies or people who are really, really unable to afford services.
We do the trimester. Some capacity, but very minimal.
I was just going to say, if it's bleeding in pregnancy, they can get an EPAS referral, and then they can get
things done there.
That'll be done.
Yeah.
Yeah. So then they'll get a good one here. But if it's just routine,
Yeah, it was just I realised we hadn't mentioned about the specialist ultrasound services as an important thing for you to be aware of. So 13 to 20 weeks, we're going to be referring our patients to EPAS or A&E if it's urgent. Obviously, EPAS is ideal because it's a one-stop shop, which I'll touch on in a minute. Ultrasound to look at cervical length. Something really important to look at on all your reports is the cervical length. And again, a reason to refer back to Royal Women's if the cervical length is shortening at any stage. So the cervix should be closed and 2.5 centimetres long. Referral to delivery suite for speculum exam over 20 weeks, really? It's in the 13 to 20 weeks. You wouldn't really be referring to delivery suite. That EPAS is really your go-to for that stage. And looking obviously for that not all bleeding is related to the pregnancy. So there may actually be local reasons why people are bleeding, polyps, trauma, infections. So don't assume. And people aren't always sure where the bleeding's coming from. So sometimes it's hematuria, sometimes it's bleeding hemorrhoids, but it's people are reporting that they're having bleeding in pregnancy. And that's sometimes about patient anxiety and awareness. So the EPAS clinic, which is the Early Pregnancy Assessment Service, it operates at the hospital Monday to Friday from 7:30 a.m. It requires an e-referral and a patient to be needs to come with an appointment made. You can contact there's a number for EPAS for us to do those referrals, and there's an after hours nurse manager supervisor if the clinic is closed. So if you've got referrals that come outside the normal operating hours. As I said, it's a one-stop shop. The patient will be seen by a doctor. Any necessary blood tests will be undertaken. Scans will be undertaken. And patients will be just given their options, whether that be a watch and wait or whether that be surgery. It's a one-stop shop. The patient will leave there with a management plan in place, and you'll be informed of that. Both medical and surgical miscarriage management options are offered to patients, and we get pretty quick information back on those EPAS visits. Usually it's a fax straight back as soon as the patient's seen. It's really quite effective and efficient information, so we know what's happening with our patients. Again, you know, there are times when you're not sure whether it needs an EPAS referral. And again, you know, sometimes it's a discussion you can have with the patient, sometimes and with the services. So, you know, we may be happy to watch and wait with the patient if we're looking at whether or not there's been, if the pregnancy appears to be viable on an ultrasound that we've undertaken, we might be happy to review that in a week and see whether fetal growth is sustained. But again, if you need advice, just call. The information, the services are there to provide us with support, and it's just up to us to avail ourselves of it. Yeah, you can call EPAS. One of the things I suppose is everything's great until it isn't. So one of the things that we will be is often the first people to identify things that are going amiss in a pregnancy. And one of the obvious ones is an abnormal oral glucose tolerance test. And so there are some patients who you'll have already identified as perhaps high risk, people who've had GDM in a previous pregnancy, or people who are overweight, or people who've had family history. You may have had an early oral glucose tolerance test on those patients. There is a really good flow chart on the clinical business rules that gives you a what to do next for those patients. As you can see, we've got the high-risk patients who will have the earliest screening, and then the routine screening at 28 weeks for everybody else. And what do? You refer them on. So if they're falling outside the normal parameters, you're going to be contacting the diabetic educator and getting them seen up here in the clinic. Most of them can maintain shared care. So depending on where they sit and how they're responding, often they'll be continuing with their shared care but being monitored by the diabetic educator and the clinic. We're again blessed with fantastic endocrinology services up here, and patients are really comprehensively managed and very educated about their condition, and it's a very good service. Patients will be prepared for any changes in birth planning that may be required because of their glycemic control, and they may be offered extra ultrasounds in the 3rd trimester to look at growth and making sure that everything is going as to plan. And then from our point of view, important that those patients get their follow-up, so making sure that they have their postpartum oral glucose tolerance test. It's easy for those things in the chaos of a new baby to go by the by. So it's just really important to bring that up at the 6-week check, and then to keep it in mind if you haven't seen that result come back, to make sure that the patient gets that done. Hypertension in pregnancy. So again, on the clinical business rules, there's really good guidelines there. We don't have to remember everything. It's there for us to read up on. And I find it's helpful. I have a shortcut to the clinical business rules on my desktop. It's just easy to do. So to identify patients, making sure that, the simple things like making sure you're using the right size cuff, making sure that, you've given the patient time to settle, rechecking it. If you're using an automatic cuff and it's abnormal, go back to a manual cuff, recheck it. The automated cuffs are fantastic, but they're not as accurate as, an old SFIG. And again, if there's anything that you're concerned about, to refer it up to Royal Women's Hospital. So blood pressure of 140 on 90 up to 150 on 95 without any symptoms will be assessed in the day stay unit within 24 hours. But if the patient is symptomatic, they've got to be reviewed that day. So, obviously if the patient has headaches or flashing lights or nausea or anything else, you've got to recognise that as urgent and refer it up. Again, no harm in making a call. If you're not sure, call rather than wonder or sit on it and wait and see. If you're not sure, call. That phone call takes all the worry off your mind about whether you've done the right thing or not. Just realistically advise the patient that if they are referred up here, it's not going to be an in-out thing. We all know that hospitals work on administrative stuff, and the patient's probably going to be up here for a few hours by the time they get checked in, settled, monitored, decisions are made, and they're sent home again or kept in. It's going to be a couple of hours before they know what's happening. So just setting that, and especially if patients, if it's not their first pregnancy and they've got toddler care and stuff to think about, just giving them the heads up that, that they need to have plans for the rest of the day, really, so that they don't have the added stress of worrying about toddlers at the end of daycare and things like that. The Royal will do the monitoring. We don't have to do anything at that point. So you don't have to order bloods, you don't have to order anything. They'll come up here, they'll be assessed, they'll be monitored, and anything that's required will be done here. Again, one of the common things we have is thyroid diseases in pregnancy. So we obviously have a lot of patients who come into pregnancy with pre-existing thyroid disease or known positivity of antibodies. So those patients need to be checked a bit more carefully. Patients that have a high BMI or low BMI, looking to make sure that we are identifying changes in their thyroid requirements or the emergence of thyroid problems in this pregnancy. So making sure that we think of it, basically. Residing in areas of known iodine deficiency, I don't think we necessarily have to be concerned about that in our locality, but if we've got patients who have recently migrated, that may be more of an issue. Looking at medications that may have been affecting their thyroid function over time, looking at patients who may have had an unexplained pregnancy loss or infertility, you may want to look at their thyroid function. So although it's not kind of a routine test of pregnancy, it is something that kind of lingers in the background as something that not to forget that it may be influencing things, and there may be a need to check patients. The requirements for thyroid replacement change in pregnancy, and most people will need a 30% increase in that from conception in their replacement. Again, there's great advice here and there's great services here, and there are clinical business rules around thyroid management. So you don't have to remember this stuff. It's there in writing for you. And these flow charts are there for you to refer to. So it's really to be aware of those patients that you might want to be watching the thyroid function, or being aware that thyroid requirements change in pregnancy. If you kind of keep that in mind, you're not going to go too far wrong. Hyperemesis gravidarum, you know, everything from, we see everything from the slightly queasy to the patient that hasn't eaten in several days. And I think it's really, really important that we utilise these wonderful guidelines that have been put together by New South Wales Health for hyperemesis gravidarum. There's a fantastic policy that takes you through the identification of the seriousness of the patient's problem, quite aptly called the puke score. And on the clinical business rules, there is the table for establishing the patient's puke score, and the puke score then will categorise what needs to happen next, whether you can keep them managed at home as an outpatient and with what means, what tests need to be done, what the tipping point is for them to be referred to hospital. And the hospital services for hyperemesis are really good, and patients are really, really well looked after. So really you're looking at early recognition, and also in those early visits with the patient when we're first talking about the symptomatology of pregnancy, making aware to patients what is kind of normal and where they need to be telling us about the development of worsening symptoms. So unfortunately, a lot of people believe that being very, very sick in pregnancy is normal, and don't present sometimes until things are really, really, really dire. You know, they're really dehydrated and they're really cachectic and in trouble. So hopefully if we can be aware of the interventions and the sort of situation of evolving clinical needs, we can put our patients in a much better position so that they don't get into trouble and need kind of admission but again, you know, there's always going to be somebody who needs to come into day stay to be given IV medication and hydration and support. And again, we're very blessed that those services are here. Just remembering that if you are adding medications to address the nausea, that you may also be needing to manage reflux and constipation that may result from those medications. So, you know, iatrogenic constipation after you've been vomiting for a couple of days is not fantastic for patients. So just one of the simple things are often the things that slip through, and just for us to be aware of that. So part of our routine antenatal examination obviously is checking fundal height, and hopefully everybody is aware that that is a midline measurement from the symphysis pubis to the uterine fundus. And we're examining everything about that pregnant uterus. So we're thinking that when we measure that fundal height, we're measuring the fetus, the liquor, the placenta, the uterus, and we're also feeling through the habitus of the maternal body. So, you know, being confident in your clinical skills is really, really important. For those who would like to brush up on their clinical skills, there are antenatal bedside clinical tutorials that are available, and those opportunities to book are on the CESPN website. So you can book into those and get a little bit of a refresher. And I really encourage people, if you feel like you need to brush up on your clinical skills, to do that. It's really important that we don't have ultrasounds at point of care. We are relying on our hands. It's really important that you feel that you are competent and confident in that to be part of this process. Our patients are relying on that. The normal fetal size is, so you want to make sure that it's between the 10th and the 90th centile. And just, it seems obvious, but the size is the size. You're not redating the pregnancy to fit the fundal size. If the fundal size is greater than 3 centimetres or less than 3 centimetres to what you're expecting at that gestational age, that's a red flag, and that needs a phone call, an ultrasound, and discussion about fetal movements. So, you know, really, I would think that if you've got a patient who's falling outside those parameters, that's a phone call. I don't think that's something that we should be ordering the next stage of tests for. I think that's a phone call. Again, don't be embarrassed to ask, you know, and even if you're wrong, even if your clinical skills were not spot on and it was, you know, 2.5 centimetres and when it came up here, nobody agreed with you that it was outside the parameters, the patient is safe. And that's the most important thing. You know, leave your ego at the door, and if you're not sure, ask and refer on. So the pregnancy day stay, we've sort of touched on its existence. The GP needs to call the pregnancy day stay if you need a patient seen, and to fax up a referral. So I think in days gone by, there may have been a patient initiated contact, but that no longer exists. And it's really important that you call, that the patient just doesn't turn up unexpected at day stay. It's for the monitoring and treatment of conditions as an outpatient. So it's to avoid having to admit these patients for monitoring. If possible, they can be seen and assessed over a period of time, and their safety for discharge be assessed. Obviously hyperemesis gravidarum is a perfect example of a patient who's suitable for day stay. Hypertension is another really obvious one. Pharyngeal infusions, it's probably not a lot of people who are going to end up in that situation. Oral iron replacement is the preferred route of iron replacement. But, you know, there may be patients that oral iron isn't being tolerated, or it's a discussion to be had. Blood pressure is an obvious one, as we touched on before. CTG monitoring. I don't think it goes through HealthNet.
No.
It's the one thing that goes straight to the unit.
Yeah, if you talk to day-to-day midwife, pregnancy day-to-day midwife, she'll give you the fax number and your fax referral through.
Of course, it's a very immediate thing. I think it's where it's slightly different to the other referrals. Pregnancy day-to-day, yep. But obviously, if you make the wrong phone call and you ring liaison, that's fine too. They'll put you through. So, yeah, that's a referral to the pregnancy day-to-day directly. If there's a question about premature rupture of membranes, that may be a referral up to there, depending. I'd say it's probably. I think birth unit would tell you. Yep, yep. I think that's probably doesn't belong there.
From GP perspective, for pregnancy day-to-day, it's really for hyperemesis.
Or hypertension.
Even you have to start in birth unit for hypertension. So basically, the referral would be for an iron infusion if your patient meets the strict criteria, or if they have hyperemesis. That's really the only.
Yep.
Yeah.
Everything else, they'll be sent there from a hospital referral.
So some of those women who were sent in birth unit might get pregnancy day-to-day. That's an internal referral after they've been seen in birth.
But again, you know, if you call the wrong person, don't panic. They'll tell you who you should call. So the important thing is to make the call if you're concerned about a patient. And that comes to this slide, which is who do I call? So we've now got Monday to Friday a liaison midwife, and we are blessed. These people are really experienced. Chantel, there's nothing she doesn't know, and she knows who to ask. Yeah. Or tell you what to do next if you're not sure.
Yeah.
So don't hesitate to call or to text. Sometimes if you can't get through, send an SMS and the liaison midwife will come back to you. And if you can put some information about what you're calling about in that text, obviously it saves a lot of time because some of those questions may have been answered for that callback.
So that can be quite good if we text each other, but happy for a phone call either way. And in early pregnancy, please call too for reasons that reasons you might need to call. We're happy to help in that instance even before they're booked in. Or if you have a woman that you feel she needs a bit more information, you can give the woman our number.
Yep.
And we can talk to her about what needs to be spoken about. Yeah.
And I think that's really the thing that I would hope. I don't expect you to be completely across all this from this morning. Obviously, you're going to have to reread through some of the documents. You're going to have to see a few patients and get into the swing of things, establish your own sort of style around what you do. But the biggest take home from today is, if in doubt, just call somebody. You're not alone. There's a whole system here that's been really, really comprehensively thought out to support you in your care of your patients, and just use it. So obviously these numbers are all available in all your information there. So the liaison midwife is your first port of call. If it's, unless it's urgent. Now, if it's urgent, it may be urgent enough that it's an ED and you're calling the admitting registrar. Or it may be something that is urgent and that you want to speak to the obstetric registrar on call. So those things, you know, that you would normally do with a medical patient or a surgical patient or an orthopaedics patient, you would do the same with an obstetrics patient. So if it's something that you know, you think you need to speak to somebody right now, then you may be calling birth unit yourself on the patient's behalf if you don't want them to leave your room. If you want the next step known, you might be ringing the registrar, but just ring somebody if you're worried. The switchboard will help you as well. So they'll put you onto the after hours manager if it's something like the EPAS referrals are outside of hours. The obstetric registrar on call, always really helpful. And again, if it's not their gig, they'll tell you who you need to call. So, you know, like anything, the people that are working in the system, they know the system better than us that are working on the periphery. So if you call the wrong person, they'll tell you who to call or put you through, or often take the responsibility for doing that themselves. It's you know, we're really blessed. And there's also now a medical physician registrar at the hospital, the obstetric medical physician registrar. So for medical problems in pregnancy, there's actually a registrar here. So you can ask about, you know, your thyroid conditions and your hypertension and things like that. There is information at our fingertips. So the other important people to know up here, to know who's who in the zoo. So Sandra Lowe, Amanda Beach and Helen Barrett are our obstetric physicians. They are unbelievably good and unbelievably approachable and an absolute font of knowledge. And their clinics are really comprehensive. Diabetic services, Sume Lau is, again, fantastic. Patients come back really well informed, very much across their disease and where they're going next. We may need to speak with genetic counsellors through maternal fetal medicine, and Deb Kennedy is the sort of go-to there. Deb will be speaking to us this afternoon about medicines in pregnancy. There's nothing she doesn't know. She's fantastic. Font of knowledge, and you know, we're very lucky with to have such expertise. We also have the clinic that's specifically for patients who've had sphincter injuries in delivery, the Oasis, and follow-up after birth for instrumental injuries and things like that. So there's that clinic. Physiotherapy services here. There was a time when it was really hard to get patients into hospital-based physiotherapy at the Royal. That isn't the case now. It's really great service and, again, very patient-centred and very accessible for patients. And so that's them in antenatal situations where you may have, you know, symphyseal pain or things like that, and obviously for postpartum situations. The lactation services we've touched on, again, a really amazing service and fantastic advice on the end of a phone as well, very realistic, very patient-focused. But if you need some running advice on what to tell your patient, or you've got a patient you're worried about, just call them. They're really approachable, really helpful, and they'll see the patient if necessary, bring the patient in, do whatever's necessary. Or in some cases, you know, unpopular opinion, but not all lactation services based in hospitals bully patients into breastfeeding if they're failing. So, you know, sometimes I've had 2 patients where the key message from the lactation service has been for them to stop trying. So don't worry that the patient's going to be bullied by a hospital-based lactation service. They're not. It's really good. MotherSafe, we've touched on. If in doubt, call. There's a lot of information online with MotherSafe. There's a lot of drugs you can look up online. But if it's something that's kind of not there or there's a bit of nuance to it, just call. If they can't give you the answer straight away, they'll go away, research it and come back to you. And I mean research it, tell you stats, tell you all sorts of things that, you know, probably way beyond what you need to know, but incredibly informative service. Obviously, a lot of our patients strike problems in pregnancy. Sometimes it brings up a lot of issues with relationships, with support systems. So the hospital has a great social work department. Obviously, it's limited with, you know, what it can do for people, but don't be frightened to ask again for advice, and patients are really well supported. And again, people with a font of knowledge about what services are available and often will help advocate for patients in situations of, unfortunately, domestic violence and homelessness and things like that. There's a preterm birth prevention midwife. Again, we've probably gone through other means for the patient to be needing that person. So we've probably rung the liaison midwife or we've run birth unit and they've been referred through to that person. But that person is contactable if you need to. The fetus phone for maternal fetal medicine, if you need a patient to be seen through there. So obviously that might be if there's anomalies and things that show up on scans, or you know, ideally, you know, if there's been preconception issues, these patients may have already identified. But again, don't be frightened to call. If they're not the person you need to speak to, they'll put you on to the person you need to speak to. So key documents from our point of view. I think that one of the most valuable things is the little booklet that you've been given today. That's a pretty comprehensive collection of information that will be your survival guide. But just be aware that printed documents become out of date quite quickly. And that's why I'd really, really like to encourage you to use the clinical business guidelines. And as I said, I have them as a shortcut on my desktop. I can't pretend to remember this stuff. And I've been giving this talk now for 4 years and I still stumble over it. So I think it's a really good thing to just get used to referring to it if you're not sure. The yellow card is obviously something that is it's supposed to be like the golden ticket of the patient in pregnancy. They should have it with them all the time because obviously things happen. People have car accidents, people faint in shopping centres. And as soon as somebody sees that yellow card, it not only identifies that the patient's pregnant, but it tells where they've been at. It's a great source of information. Unfortunately now, people don't carry it quite as religiously as they used to because, you know, we walk out of the door with our phone and a set of keys and not much else. The days of a big handbag for everybody are probably a bit gone. And, you know, it is something that we're currently rattling the cage about trying to get that digitalised in some way, but that's years off, I think. So trying to reiterate to patients very early in the piece what a vital piece of information that yellow card is and that they really should carry it with them all the time. It's got so much information and, as I said, even the sheer fact that a patient has it identifies to somebody who's maybe a first attender in an accident or something like that, that there's a pregnancy involved. If patients don't bring their yellow card to the appointments, which is again something we strike a lot, I try and get them to, I print off my record of their examination on that day and ask them to staple that to their yellow card. Sometimes I'll get patients to take a photo of their yellow card if they're not going to carry their yellow card with them. So from their last visit, just to have that. And I tend to do this with other documents as well, like advanced care directives. I get people to try and attach it to their in case of emergency number in their phone. It's just sort of something that might be helpful. There's also, just to reiterate to you that the current protocol is under review. And so just to keep your ears and eyes open over the next few months, CESPN will extensively advertise when the protocol changes, but it will rely on you guys being, opening those emails or reading those updates. So once you're part of the antenatal shared care system, you'll get an antenatal shared care update that comes out on a quarterly basis that is incredibly current, addresses any changes, any topical things that are happening, and a lot of thoughts put into that document. So please don't just let it go to junk, or make sure you open it and read it. We're working on trying to make that a bit more identifiable so that it doesn't just get lost in the general CESPN inbox stuff. But again, just be aware that that's going to be happening on a quarterly basis. You'll be getting an antenatal shared care update and vital information. Any changes will be in that. Safer Baby Bundle website, another really helpful thing to make yourselves aware of. And there's also e-learning, so you could get some points from doing stuff like that. Antenatal education, we have clinical placements. So if you go onto the CESPN education things where you enrolled to come today and this afternoon, there are opportunities to come in for a clinical placement, either in the clinic or with an obstetrician doing bedside examinations. Again, really, really valuable to upskill and also to develop those relationships with the people that you're referring to. We're blessed with really enthusiastic and incredibly generous obstetricians in terms of their time and their enthusiasm for the program, and those opportunities are so valuable. There's also a neonatal clinical placement available, so that you can have some time in newborn care. Again, if you need some practice with doing newborn baby assessments and seeing what happens in newborn care these days. It's a long time since I did intensive care paediatric placement, about 35 years or so, I think. Lots has changed since then. There's a GP shared care conference every May and November, so this afternoon and again in November, where we really take a lot of feedback from each session to devise the next session. So after today's session, there'll be an opportunity in the feedback for you to say subjects that you want to touch on again, or topics that you want discussed. And we really take that seriously when we design the next one. We put a lot of time and effort into going through those responses. We're very well supported by CESPN there, who do a lot of that statistical analysis for us and tell us, where things rank in terms of people's needs. There's online learning through the PHN. There's GP learning through RACGP, and there's a lot of opportunity to improve your confidence in your obstetric care. So some specific item numbers that are probably important for you to know. The antenatal visit is a specific item number at 16,500. So it it's a standalone, but if you also manage a medical problem that's not specifically related to obstetric care, you can co-bill. So it's important that you understand the MBS guidelines on that. I think it's something that we don't get taught a lot about, the intricacies of managing the MBS guidelines and understanding them. But I think sometimes we do more than we bill for. I think general practice, that's probably an across the board thing. So just making sure that you're aware of the nuances of those item numbers and that you're using them properly. 16591 is a birth planning appointment. It can be done anywhere beyond 28 weeks, as long as it includes a mental health screening tool and a domestic violence and domestic abuse assessment. Just be wary though, before you invest a lot of time assuming you're getting that item number, it's probably worth checking on PROTA, because sometimes that's billed in the clinic. So just before, because it can be done by obstetrician or GP. So before you kind of think to yourself, oh, this is my visit for that, because the patient rebate for that is $162.50. So it's a bigger billing item. And I know it sounds a bit petty, but you don't want to have invested all that time with the assumption that the patient's going to get that rebate and then find that in fact it's already been done by somebody else and you've now invested the time and you're now billing them a time-based consult, which they may only get $80 back. Just a bit of kind of practical advice. There's an item number for the postnatal consultation, 16407. I think the telehealth stuff, although it's there, is probably not so relevant to us now in Sydney metropolitan area. And I really think if you're doing antenatal visits by telehealth, there's a problem. That you need to be laying hands on bellies. We're not in the midst of lockdown anymore. I think different if you're in rural practice, but I think nowadays remote antenatal clinical assessment is out the door. So I have real concerns if you're billing telehealth in the Sydney metropolitan area for antenatal and postnatal assessments. Again, don't forget to do your Edinburgh scale and ask about patient safety. Of course, in general practice, hopefully part of the beauty of this is we know our patients well, but we all know there's stuff about our patients that we don't know. And pregnancy is a time when sometimes these things come to light, particularly coercive control. And it may be necessary for you to find the opportunity. I think it's absolutely essential that that postnatal visit has at least a period of time with you and the patient alone. No partner, no mother-in-law, no mother, nobody else, you and the patient alone. And you may have to contrive some opportunities for that to happen. I think I've certainly experienced over the years a number of mothers-in-law who are there to observe what's said, to report back to the coercive husband. So just be aware that this may be one of the few opportunities that a woman has to declare her safety or otherwise. And you may be the only person she trusts to do that. This may be an opportunity of vulnerability that you can really make a difference. And to that point, also making sure that in that time that you have with the patient, that you establish a safe way to communicate with them, so that if their phone numbers that they feel safe to be called on, and email addresses that they're safe to receive information on. So just be aware, you may be one of the few people who's in the know about their situation. So use that postnatal visit well. You know, an intimate examination is often a great way to get the mother-in-law out of the room. You know, just say it's completely inappropriate that you're here for this examination. And also don't forget that you can bill for the urine pregnancy test if you're doing that in your rooms. And there's a learning module that for non-directive pregnancy counselling that you can do through the GP learning on the RACGP education. And once you've fulfilled that criteria and done that e-learning module, you can bill for 4001, which is a non-directive pregnancy counselling. And goodness knows we do a lot of that. So you may as well have done the learning module and be able to bill for it specifically. So, you know, we do this for the care of our patients, but we also do it for a living. So, you know, knowing that the appropriate item numbers that you can use that relate to what you're doing is really important, I think, and to use them wisely. So we've bombarded you with a lot of stuff today. As we promised earlier, that we do have a guest appearance by Louise Fay, who's one of our really supportive antenatal shared care obstetricians. And I'm sure there are things that have come up through the meeting this morning that you might like to come back to in her presence to ask more specific clinical questions or management questions. So this is Louise.
Hi everyone, welcome to the Royal.
Has anybody got anything that they'd like to bring up with Louise? Yeah, actually I didn't, I meant to come back to that.
You know, it's at the moment, because the Royal doesn't have a clinical business rule about it, so you have to order it externally through DHM, but that's available through Medicare. So we just
I think it's in your handouts. So patients who are RH negative from 15 weeks can have a Medicare rebated fetal RHD status established. And as Louise said, at the moment it's through Douglas Hanly Moir. So very important, I think, for us to know that we can refer our patients for that. So when we're identifying in that first group of blood tests the RH negative patients, to bring it up with them that this is a test that they probably should have from 15 weeks and it's covered by Medicare.
Oh yeah, sorry, I thought you'd covered it.
No, I meant to come back to it because it wasn't in the slides. So.
Oh yeah, because it's not kind of part of the thing.
New. Yeah.
And then the other thing is, so you have to be at minimum gestational age of 15 weeks, and you can't do it beyond 26 or 27 weeks, you know, because that's when you'd be given your first dose of anti-D usually. Even when patients say, oh, my partner is rhesus negative, we still recommend that they do it, you know what I mean, just to ensure. And there was another, you have to know if there's previous antibodies. So if there's been previous antibodies, they need to know that. But you'd be screening for those anyway, either at booking or at the 26, 28 week. Any other questions? Yeah. Oh, no, we go hard. We use PPIs. Yeah, very effective in pregnancy. We wouldn't have any concerns about using them. Oh yeah, good question. So usually, hopefully, because there's a big medical obstetric presence here in this hospital, we've got 4 obstetric physicians now. Obstetric physicians at the Royal, and there should be a plan made for a lady who's going home on antihypertensives, like a very specific plan. They also do follow patients up or recommend a liver function, renal function, and a blood pressure review at 6 months postnatal. Now, see, we don't capture these ladies, but you would in the community, like for, say, women who are bringing their babies for vaccinations, and you might just look at their file. So they should have a specific treatment plan because
And
If-
they usually have a very strategic step down plan
Yeah,
and a what to do if. So
it should be in their discharge letter from the hospital, not just the birth summary. Because if somebody's on 3 antihypertensives on discharge after having a baby, that's quite a significant number. So they would be at a minimum of 4 to 6 weeks weaning down. But if you ever have any questions, you can just call Chantal, and then we'd look up the file and kind of confirm.
Sometimes they may change GPs.
yeah.
So in that instance, call us and discuss it with you.
Yeah.
They won't bring.
Yeah, they mightn't,
Yeah.
or they'd come with their baby and
But there
think there's
would be
nothing wrong with them.
information.
Yeah.
So again, you know, if they've had hypertension in pregnancy and they're on 3 medications, they've been seeing one of the physicians. So there will be a record of what was planned. It's just a matter of getting hold of that. So calling up to the medical obstetric registrar or to the liaison midwife will get you access to that information. Yeah.
So, as in like they're past the first trimester, yeah. Look, they can be reviewed still in EPAS. We review an EPAS up to 20 weeks. So you can still access it. It's not a problem. And then delivery suite after 20 weeks. Yeah. Mm-hmm. Yeah. Yeah, good question. So the new guideline is a TSH of 4. So obviously don't treat if it's under 4. I guess you'd have to take into account, is there prior history? Is there strong family history? You know, say a lady who's been previously treated in a prior pregnancy. But yeah, the guidelines have changed because there's a lot of probably overtreatment of subclinical hypothyroidism, and the long-term data for babies or for their offspring, like the kind of 5-year and 10-year follow-up from an educational review is very reassuring, like just to reassure the patients. I think they all think their children are going to be desperately affected. Yeah, like we do have the cutoff, yeah. But we're happy for you to manage if you're comfortable managing thyroid disease. And then when they come to see us for their booking visit at 14 to 16 weeks, but you could, like if you're, I suppose you see the patients so early, like at 5, 6 weeks, and their TSH can be all over the shop, either like very, very low just as a result of HCG levels, or if it's borderline, I suppose you could repeat it in 2 weeks. You're not missing out on very much, yeah. Mm. And a lot of it is like there's no strict cutoffs, but there's clinical judgment as well. Yeah.
And again, you can always ask for advice, you know. I think that's, as I said, the biggest take home from this intake is to really, we're not expecting to teach you obstetrics, and we're not expecting you to come out of here knowing what you do at every stage. But what we're trying to do is give you the framework to work within and the people that you need to be able to contact. And, you know, you're not going to go far too wrong if you follow those protocols and ask if you're not sure.
Yeah. And we do have the intake evening if people want to come and do some clinical practice, you know, for seeing women, say, who are long stayers, like hypertension, preeclampsia, women from outside of Sydney metropolitan area, you know, they're just bored hanging around with short services and things like that. So they're very happy for clinical presentations. And then we just do a tour of the hospital in general, just so you're familiar with what's what. And then for any gynecology services as well, if anyone wants to ask me any questions. We've got a big gynecology service here. You're probably aware of that.
No, you go ahead.
The only way you're going to get a Papa A would be with your I just want to make sure there's nobody else doing like random because most people go with it.
Yeah.
Really.
No, it's probably the other criteria that are kind of identifying those patients to us in general practice.
Yeah. 12 weeks.
12 weeks.
Yeah, as long as it started before 16 weeks. So the only people, who are doing PAP-As are the people who are doing the preeclampsia screening tests, and that is confined to places that are quite expensive, so. But then if you look at the other clinical criteria, so like a 42-year-old woman might score like less than 1 in 20. Oof.
You right, Chantal?
Might score very low for preeclampsia risk, but we ignore that, and then they're probably going, I've just paid for that whole thing. But it's incorporated into their early structural scan anyway. But for the clinical criteria, like did your mum have preeclampsia, did your sister, are you over 40, have you used donor gametes, have you history of it, they'll cover most of the people that we're going to see with early onset. So the PAP-A, look, if they don't have it, there's very few women who would have very low PAP-As, and then they wouldn't have other features that would be picked up. So the high uterine artery, so like say, for example, Spectrum doesn't do PAP-As, but they do uterine artery Dopplers. You know what I mean? So there are things if they're kind of above the mean. And, once again, always ask, we now have a big long list, there's barely a woman in this hospital that's not on aspirin now because, they're all having their first baby over 40 or their third at 45 and stuff. Until 12 weeks.
12 weeks.
Yeah.
Yeah, that's right.
Yeah, you don't need to start it until 12 weeks. And remember, calcium also improves obstetric outcomes for hypertension. So 600 if they have a fairly balanced diet with dairy in it, 1200 if they don't, which I wouldn't see many people with very little dairy in their diet.
But just be aware that as soon as you add calcium, you're adding constipation. So making sure that, we talked about before, when you're treating their nausea and vomiting, that you're probably causing them to be constipated. So again, if you're giving them calcium, make them aware that it's probably going to constipate.
To take them off their multivitamins the minute you diagnose hyperemesis, because a lot of the like Elevit and those things are just
dreadful.
Yeah, just triggers. Yeah. And, obviously you went through everything, and the fetal medicine services, the preterm birth clinic, use all of those services because they're very important and they do make a difference. And people are very, very accessible, very happy to see our patients, very happy to answer questions, queries. It might just take, just even talking to the preterm birth specialist midwife, does this patient reach criteria? Just in case it's not very clear from the clinical pathway, but always ask, because the services are very readily available, and we'd prefer to have overuse than underuse.
And I really think the other thing, that's I think what I think is so unique is that this is a tertiary referral hospital. This is like the gold standard of obstetric care, and yet everyone here is approachable. It's staffed by real people who talk to you like a peer, and nobody's going to make you feel foolish for asking questions. Everybody's going to be happy to know the voice and the face of the person whose signature's on the referrals. So don't hesitate to pick up a phone and call people and ask questions if you're not sure. It can be really stressful if you've got a patient that's varying outside of what you're expecting and you're not sure what to do. So just call. It's really the biggest take home I can reiterate today is that don't hesitate to ask questions.
I just wanted to plug again Health Pathways. Can I just get a show of hands who uses Health Pathways? Oh, great. Okay, so everyone already knows about it. Late last year, you now have to make your own individual login, but that will also help you get CPD points for the pages that you use. They'll track that. So worth doing that. And a lot of what we've talked about today is like covered. I'm pretty sure the rhesus one was recently updated. Or maybe they don't have the information about the new test that you can do. But there's just information about which women meet criteria, for example, for rhesus, etc. But yeah. And again, a plug for the hospital. Like, you know, we're so lucky. Like I think a lot of women come in going, oh, you know, we're not sure, especially first pregnancy women, like, you know, should we, is it okay? Is it safe to go down like, you know, the public system? But I always say we're so blessed in this area to have such a great service publicly. And so I never hesitate to recommend it. And you also get like extra things like, you know, if you do have diabetes, I personally had gestational diabetes, and I didn't realize, because I had a private obstetrician, you're not then accessible to the dietitian and everything in the public. And so, yeah, there's so many great services that I think women get when they're linked into the public.
It's really comprehensive.
Really comprehensive.
We have, in addition, we always plug our physio department.
Yeah.
So, and we're really promoting the use of physio for like long-term pelvic floor health, regardless of your choice of mode of delivery or your prior mode of delivery. We've got a very dynamic service here now. We've got a free drop-in clinic for all women, 2 afternoons a week, you know, so people who like just might want to take an hour or two off. And the physios who work here, obviously, because it's all women's health, they've got an excellent pain service, you know, because this is a big pain referral service here. So even if they've got pre-existing pain and are pregnant, or say from a gynecological perspective, or if they've had any major perineal trauma in the past and are planning a vaginal birth or any prior history, you can refer them. I mean, we would do a lot of in-house referrals, but if you feel kind of like, oh, you know, she's 28 weeks and we haven't, and you're talking about it, feel free to refer in. Is it?
No, I don't think.
No, I think it's through the department.
Through the department.
Through the
yeah.
department
But it's
And their numbers in that.
that
Yeah.
book.
guideline.
it's changed a lot recently.
Chantel just wants us to go back to the business guidelines.
Yes.
So just a reminder, guys, that everything you need to know about specifics is in those clinical business rules, and they're available on the Royal's website. You just go to health professionals and scroll down, and the clinical business rules are there. And antenatal pregnancy care encompasses everything, and then there's specific things there. There's physiotherapy we touched on. Whoops. Oh, hello.
Oh no, just ring the department.
Ring the department. It's not there. But there.
If you click on this antenatal pregnancy care, like you think there's not a lot, but
Then look at all that that's there. So things like, you know, the things that we strike, like herpes in pregnancy, you know, they're things that you don't see for ages, and then you suddenly see and you're not quite sure what you do and how to advise somebody. It's there. Iron deficiency and where you go with somebody who's, you know, got thal minor, or what do you do? And as I said, we can't remember all this stuff. We remember guidelines for everything. So, you know, utilise this stuff, and it's up to date. We know obviously the booklet that you have is up to date as of now, but in a couple of weeks' time, something might change. This is always going to be up to date. So just, as I said, I have it as a shortcut on my desktop. I think it's a really good way to go. You've got the, you know, low-lying placentas. You know, obviously you'll become familiar with the measurements you're looking for, but, you know, sometimes you second guess yourself. Well, the information's there. You can look it up. So just having that. And also, I suppose it came up the other day in the meeting preceding this, where we were just having a bit of just documenting if patients are refusing monitoring or investigations or immunisations, just making sure that you're covering yourself with documentation of that situation. where the patient is refusing to follow your clinical advice, just making sure that you document that really well so that things don't come back to bite you. Anything else, Chantal? That you...
Someone asked about morphology ultrasounds and how to get the reports to us. So you could, ideally, we would love you to give them a morphology referral at your last GP visit before the booking visit. So when that you see them at 20 weeks to review the morphology. So if you can give a copy to the woman at that time, or you can email a copy to the woman and just CC us into the results of the morphology.
So it does come to you if we CC,
yes,
because we were just debating that amongst ourselves, because my fear is that it gets lost in the ether.
I'd say
It's probably best not to do that, actually.
It's probably best that the patient has it.
Yeah,
Hand them
if
the
the
report.
patient has, that's the best way.
Email it to them and they can't lose it.
Yeah.
On how frequent says, does it require a morphology or is a yes, no tick option? I just don't know what that does. I always tick yes.
Yeah, I'm not.
Giving them one.
You're giving them the referral.
Yeah.
Yeah, you're going to give them.
You're going to give them that. I don't know. I must say I haven't noticed it. So that's a really
Just tick yes, because then you've done it.
yeah.
Electronic.
It's not going to trigger us to do it.
No.
Just FYI.
Yeah.
It sounds like it does, but no.
No.
If you've got any questions about electronic referrals, the team is actually out there.
Yeah, and they're actually doing a little presentation at the beginning of the update this afternoon. So a great opportunity and a great opportunity to feed back things that are perhaps working and not working as well. We are really trying to advocate the improvement of the transfer of information between the hospital and GPs specifically, but just that communication, trying to make that as easy as possible. So, any feedback that you can give to them would be great.
The other postnatal information that from us, if you don't receive it, call the liaison midwives and we can send it.
So simple things like just to share information from our perspective in the clinic. If you send your patients to laboratory or DHM, we can look all of that up online. Or SEALS, obviously, because SEALS is here. So, and like SEALS will do a GTT and SEALS will do like even level 7 in Prince of Wales private will see your patients. You know what I mean? You don't have to be a public or a private patient. It's quite quick access. And then just, handing the copy, like, because we still have some paper files and some is online. I mean, you probably all work paperless, but unfortunately that doesn't compute here. So, that, it's better than kind of getting pathology done at other places that aren't online, because then we have to go and phone and fax and, patients sitting there and smiling at each other. Run out of things to talk about.
Takes away from the education.
Yeah.
And if your patient has a prior poor obstetric history, so, say, for example, if they've had a high risk NIPT in the past and required termination for Down syndrome or anything like that, our fetal medicine department are happy to see those people, not for they can't afford the NIPT, only for certain people, but they will do the early structural scan, you know what I mean, for people who want to be very reassured, and they'll do the morphology scan. So it's not like you have to have an abnormality or fetal abnormality to see fetal medicine. They will very happily see patients, even if that patient had that problem like in another state or country or something like that.
I had that. I had a patient unexpectedly born with a major cardiac malformation. They'd had their scans done in India and then migrated here, and ended up, the subsequent pregnancy, obviously enormously anxious about the well-being of the baby. And I just rang maternal fetal medicine, explained the situation. They saw them and reassured them and did early scans for them. And, it was just really, really great at allaying that anxiety, knowing that they were being investigated in a major unit. It's great.
And there is a fetal cardiac echo service here, not just fetal medicine, but as in pediatric cardiologists who specialize in fetal cardiology. I mean, normally those referrals would be in-house, but they are accessible, for parents who have congenital cardiac abnormalities and for prior siblings with like obviously what Maureen is saying is fetal medicine saw them first, but it would have had a fetal echo from cardiology here. So it's all free of charge to the patient, which is really good.
So we do animal.
Oh, I mean, CVS, it's like everything is done here, that's done. Yeah, I think people are under the impression they can only get in here when there is a proven problem, if you know what I mean. But if somebody has a high risk NIPT, you can refer them to the fetus phone and they can take it from there, because we would do the invasive testing and we would do the termination in the hospital as well. You know, and it takes a lot of expense out of the hands of the patient.
Anything else? No. Great. Well,
And one last thing, just when you're doing a NIPT, always add a NIPT, not just by blood test, NIPT and scan.
Yeah.
You've had people come with no fetal hearts for their early structural scanning. But obviously the NIPT is going to pick up the fetal DNA, so always do NIPT and scan.
Yeah, I think most of like the obstetric ultrasound places do a
Oh, they
bulk
would,
build
yeah.
sort of ultrasound. So it's actually just as much.
It's just as part
It's the same cost to them if they do like it at
through Sonic,
yeah. So if they do want to do the NIPT, then they might as well go through somewhere like
And that also do
Okay.
the early structural.
Yep. So guys, thank you for your interest in joining the program. It's great to see such interest in the shared care program and to have new GPs come on board. It's great to provide this continuity of care to our patients and just to keep expanding the number of people whose interest in obstetrics for our patients is fantastic. Okay.
Thank you.
Enjoy your break now. We'll reconvene at what time we're reconvening at?
Lunch is at 12.
Lunch is at 12.
12:45.
At 12:45.
Okay.